Hi, my name is Ginger Holt, and I'm going to be talking about orthopedic pathology. I have no financial disclosures to share. This talk is going to focus on 7 orthopedic tumors, and then we're going to follow up those tumors, looking at the tumors, how they occur by location, and then I want to discuss biopsy principles and how they may present on the examination. Some important basic things I want to talk about when you're looking at questions, and we're looking at orthopedic oncology in particular. There are some features of the STEM and there are features in the answers that I want to make sure we have some ground rules on. If you look at tumors, they basically occur in 2 age categories, less than 30 or greater than 30. The primary bone tumors that occur in patients less than 30 are Ewing sarcoma and osteosarcoma. And patients who are over 30 are at a propensity of having chondrosarcoma, metastases, lymphoma, myeloma, or chordoma. In the contrary, benign lesions that occur in patients less than 30, osteoid osteoma, osteoblastoma, or chondroblastoma, and giant cell tumor and Paget's disease tend to occur in older patients. So instead of remembering specific numbers, specific ages, it's helpful to remember some diseases occur in younger patients, usually less than 30, and the other diseases occur in patients who are older or greater than 30. Pain can be very specific to orthopedic oncology patients. Pain that is not associated with trauma. So a patient who is stepping off of a curb, getting out of bed, very minimal trauma or very minimal velocity, when a patient has significant pain, it becomes very important. Osteoid osteoma has a very specific pain pattern. It's easy to test because it is so specific. These patients don't have weight-bearing pain, they don't have pathologic type pain, but they have pain that occurs in a diurnal pattern. It may occur at 2 in the morning and 2 in the afternoon. Patients will tell you that it is immediately relieved with an aspirin or an anti-inflammatory medication. This is really important because the pain pattern for osteoid osteoma is so specific, it's very easy to test. Soft tissue sarcomas, on the other hand, are deceptively painless. So don't be fooled by a lesion that has an insidious growth pattern. It's growing very slowly, and this can easily be confused for something other than a soft tissue sarcoma. I also want to talk about treatment. We can categorize these in big groups, and sometimes it's easy to remember. Patients who have a Ewing sarcoma or osteosarcoma are treated with chemotherapy and surgery. Patients who have a soft tissue sarcoma are treated with radiation and surgery. Chondrosarcoma is treated with limb salvage surgery alone. We don't use chemotherapy or radiation therapy as an adjunct. Metastatic disease, lymphoma, and myeloma are treated with some sort of fixation, a nail, a plate, and radiation therapy to the entire field that was treated. Giant cell tumors, osteoblastomas, and chondroblastomas are treated with intralesional resection. So these lesions undergo a curettage, a cleaning, maintaining normal bone around them. Here we see osteoid osteoma again is almost an outlier. Osteoid osteoma is treated with radiofrequency ablation, again very specific to osteoid osteoma. This is the standard of care for treatment of osteoid osteomas and so specific that it is easily testable. When you're looking at treatment options for a patient, don't treat a patient unless you have a diagnosis. The majority of time, if the option to biopsy a lesion is in your answers, it is the answer, especially if you haven't gotten a diagnosis for the patient yet. When we talk about treatment and we discuss surgical excision, sometimes this can be confusing, and I want to go over the 4 types of excision that exist. Incisional or intralesional excision occurs within the tumor or within the lesion. An example of this is a giant cell tumor, in which we actually enter into the tumor, take out the tumor piecemeal, and then use a burring tool to clean the tissue out back to normal bone. A second type of excision is a marginal excision, and this occurs just at the tumor margin. An example of this is a low-grade liposarcoma or a fatty mass that has a very firm margin. This is most commonly used for soft tissue lesions. The third type and most common type of surgical excision we see is a wide excision. This takes a normal cuff or a normal margin of tissue. Usually that margin is muscle. Less commonly, we use a radical excision. Usually this is an amputation. This removes the entire compartment affected. You can see from the schematic on the left the difference in a radical excision, which is far away from the tumor, removing the entire compartment. a wide excision which leaves the majority of the compartment and uses just a small cuff of normal tissue, a marginal excision just at the tumor border, and an intralesional excision which is actually inside the tumor itself. Another key factor we're going to see throughout this talk is diagnosing bone tumors. The four big questions we like to ask. What's the location of the tumor? Epiphyseal, metaphyseal, diaphyseal. What's the tumor doing to the bone? How's the bone responding? And lastly, what's the matrix of the lesion? We'll start with the most common primary sarcoma of bone, the osteosarcoma. Told you this is a younger person's disease, so patients are usually less than 30 years old. The x-ray to the right shows us an example of the four questions we want to ask. What's the location of this lesion? This is a metaphyseal lesion in a skeletally immature patient. What is the tumor doing to the bone, and what's the bone doing to the tumor? The yellow arrow shows you that the tumor is forming a very large soft tissue mass outside of the bone. The bone is trying to respond by forming a Codman's triangle at the superficial aspect of the lesion, but the bone is very slow in responding. This shows you that the lesion is very aggressive. It's forming a large soft tissue mass with very little response to the bone. The red star is on the matrix. The matrix here is bone. The bone is haphazard in its appearance. It's very disorganized in how it forms, but it gives a more dense appearance, and on plain x-ray, a more white appearance to the bone. Osteosarcomas come in a variety of types. The most common is a central, or basically the osteosarcoma most people are familiar with. Lesser common are the surface osteosarcomas. And here we have an example to the far left of your conventional osteosarcoma. The osteosarcoma starts in the intramedullary canal. It extends circumferentially around the bone, creating a large soft tissue mass. In contrast, the two images to the right are surface osteosarcomas. The lesion in the middle is a parosteal osteosarcoma. This is a low-grade surface lesion that is essentially low-grade malignant bone stuck on the surface of the femur. The picture shown here is the most classic area where parosteal osteosarcoma occurs, the posterior distal femur. The image to the right is a high-grade surface osteosarcoma, the periosteal osteosarcoma. I like to remember this because the periosteum rides on the surface of the bone, and this lesion almost occurs in the periosteum. It spares the metaphyseal and intramedullary portion of the bone, and as it grows out off of the surface as if it arises from the periosteum. When we ask our four big questions, again, for an osteosarcoma, what's the location, what's the tumor bone-tumor interaction, what's the matrix? This is a metaphyseal lesion. What's the tumor doing? It's forming a very aggressive soft tissue mass. You can barely see it on the plain radiographic images. The bone is forming a Codman's triangle. So what happens is young bone has a very thick periosteum, and as the soft tissue mass begins to form, it pushes the periosteum off of the bone. The periosteum tries to heal and make bone, and it creates this triangular shape. When we look deeper, what is the matrix then? We see a bone-forming matrix throughout the metaphyseal region of the bone. And again, this patient's under 30, so the patient's skeletally immature. Another example, location, tumor bone-tumor interaction, and matrix. The location is metaphyseal. The red arrows show you a very large soft tissue mass that has formed, but there is very little response to the bone. You can see a very good cortical line in place shown by the yellow line. So there's very little response for the bone in response to this really big soft tissue mass that you see. And then overall, what's the matrix? We see a bone-forming matrix. Here's an example of how plain x-rays give you a good picture, but don't show you how aggressive the lesion is. This is a skeletally immature patient. This is a metaphyseal lesion. And the lesion is seen here at the tip of the red arrow. Location, metaphyseal, tumor bone-tumor interaction. You would think there's not a lot of action by the tumor, but the bone is forming a bone matrix. When we get the MRI scan, you can see that there's a very large level of activity going on within the bone. We have a big soft tissue mass beginning to form, as seen in the upper right-hand image with the red arrow. And we see a soft tissue mass on every image, T1, T2, weighted sequences. So what we're seeing here is that this lesion is so rapidly expanding, the bone is having absolutely no chance to respond. So we have a metaphyseal lesion that is extremely aggressive in a skeletally immature patient with a bone matrix. That's an osteosarcoma all day long. When we look at the histology and get a biopsy, the characteristic finding for an osteosarcoma is an osteoid matrix. So these arrows show you these small little areas of immature woven bone. This is in contrast at the bottom of the slide to mature lamellar bone. We see lamellar lines, we see the maturity of bone as opposed to the very small little islands of bone in the middle of all of these dark blue cells. Blue is bad on a slide, and we are now seeing a sea of malignant osteoblasts rimming these very small areas of bland osteoid. Osteosarcoma has to be biopsied before treatment. So again, if you're given a question and you don't have a biopsy or haven't had a biopsy, the option to choose is a biopsy. Before you treat these patients, they need systemic imaging. Our sarcomas have a propensity to travel hematogenously, so we really want to look at the chest for any metastatic disease. Osteosarcoma is treated by chemotherapy, surgery, followed by chemotherapy. Neoadjuvant chemotherapy is the term given for chemotherapy given prior to surgery, and then adjuvant therapy is a term given to chemotherapy when provided following surgery. So chemotherapy, surgery, chemotherapy. Chondrosarcoma is a malignant cartilage tumor, and in contrast to the osteosarcoma, it occurs in the older patient population. We say older than 30. 2/3 develop in a previously normal bone, just de novo. A third develop in a pre-existing lesion. The picture to the right here is a lesion that developed in an enchondroma. We may also see this in osteochondromas. When we ask our 4 questions, location, tumor bone, bone-tumor interaction, and matrix, we see that the location again is metaphyseal. The tumor is very slowly expanding. It doesn't appear as aggressive as the osteosarcoma did. It's creating an abnormal appearance to the bone and the overall bone architecture. The bone is trying to respond by slowly expanding. It also has endosteal scalloping or erosion as it tries to move out of the way of the tumor and then heal itself. The matrix is very specific for chondrosarcoma. You can see the yellow arrow is on the cartilage matrix. Cartilage is calcification. It's dystrophic calcification that occurs in arcs and rings. We also call it punctate calcifications because it looks like very small dots as it forms. And you'll notice again, this patient is skeletally mature in contrast to our osteosarcoma, which is a skeletally immature patient. Here's a chondrosarcoma arising in an osteochondroma. We most commonly see this in patients with multiple hereditary exostoses, which is an abnormality in the tumor suppressor genes, in particular the EXT1 tumor suppressor gene. The radiograph to the left shows you what appears to be a broad sessile osteochondroma. But when we look to the lesion on the right, we see that the lesion doesn't end proximally. We see dystrophic calcifications extending out from the lesion. When we look at this on the axial MRI scan, the T1 weighted image on the left and the T2 weighted image on the right shows us the characteristic finding of a chondrosarcoma that arises in an osteochondroma, and that is a massive cartilage cap. This almost looks like a big stalk of cauliflower coming off of the bone. We talk about the importance of a cartilage cap being greater than or less than 2 centimeters. This cartilage cap is more than 6 centimeters, and there is no area on imaging, whether we look at coronal, sagittal, there's no area where this cartilage cap is even less than 2 centimeters. So this is a malignant cartilage cap arising from a degenerated osteochondroma. Chondrosarcomas very commonly occur in the proximal distal femur, the proximal humerus. Chondrosarcoma also has a predilection for the flat bones, the scapula and the pelvis. The lesion to the left radiograph, if we ask our 4 questions, location, tumor bone, bone-tumor interaction, and matrix, we see a very slow expansion of the bone. If you look at the bottom of the x-ray, we see a normal cortex as we travel proximally that expands almost twice the size of a normal canal. The endosteal scalloping and erosion that is very characteristic for chondrosarcoma. We have the matrix creating arcs and rings, and then the green arrow shows you that we even have a very small soft tissue mass forming. When we look at the radiographs on 3 dimensions, the MRI scan shows you how the sarcomas, osteosarcomas, chondrosarcomas, and Ewing sarcomas actually have a very definitive border to them as they grow and progress. Metastatic disease, infections don't have as much organization as the sarcomas do. In these pictures, we're looking at an MRI scan, T1 weighted image to the left. We're looking at a T2 weighted image to the right. And you can see that this lesion does appear more aggressive on MRI scan than it did in this plain X-ray. We see that the lesion extends up into the head. It extends further down the bone than may be expected, and we can begin to see the soft tissue mass forming. Again, the radiographic appearance for chondrosarcomas is very specific. When we look at this tumor-bone tumor interaction, although these are malignant lesions, they don't appear as aggressive as an osteosarcoma or Ewing sarcoma will. The matrix itself is the arcs and rings of punctate calcifications. We see the endosteal scalloping erosions seen on as the blue arrow shows, and then the overall architecture of the bone is abnormal. So if you put your finger over the cartilage matrix circled in red, the overall architecture of the bone itself is abnormal. When we look at the MRI scan image, you can see this abnormal architecture again. The lesion is dark on T1, it's very bright on T2 imaging and has this lobular appearance to it, which is very characteristic for a chondrosarcoma. Here's an example of an enchondroma on the left and a chondrosarcoma on the right. Again, an easy way to tell the difference in the two, if you put your fingers over the lesion on the left, you have what appears to be a normal humerus. If we cover up the lesion on the right, which is in the metadiaphyseal portion of the humerus, we still see an abnormality in the cortex. The bone has begun to expand. And the two things that are very important to differentiate a chondrosarcoma from another cartilage lesion is pain and a change in the bone architecture. The histology for a chondrosarcoma is very specific. The chondroid matrix is very cellular. If we look at cartilage that comes from the end of a bone, cartilage is very acellular. As we look at the matrix here and we look at it on a close-up, we see that we have binucleate cells that occur. So the red arrow is showing you multiple binucleate cells as they occur, very specific for chondrosarcoma. The more cells, the more binucleate cells that occur, the greater the grade becomes. Here's an example showing you the blue cartilage as it moves through the bone. You see the pink mature bone. Normally a highly malignant tumor, as it moves through the bone, is going to destroy the lamellar bone behind it. This is the reason the tumor-bone, bone-tumor interaction between the two allows the bone to expand slowly over time. And it's because the cartilage will slowly push its way through the bone system without destroying it, and this gives the bone time to respond. The same goes for osteosarcomas, chondrosarcomas, and Ewing sarcomas. We want to look at the lungs for metastatic disease. The treatment, in contrast, for chondrosarcoma is a wide excision. Osteosarcomas and Ewing sarcomas get chemotherapy, surgery, and chemotherapy. Chondrosarcomas get wide excision with negative margins. Ewing sarcoma is another young person sarcoma. Usually patients are less than 30. The important finding that differentiates a Ewing sarcoma is that the patients present with a very large soft tissue mass. The soft tissue mass can create a scenario that looks very similar to infection, and these can often be confused, so you need to be very careful when a patient comes in with fever, elevated sed-rate C-reactive protein, to have a really close look at the imaging to ensure you're not dealing with a Ewing sarcoma. When we look at the MRI scan on the right, we see the iliac wing itself is filled with tumor. We see the soft tissue mass extending into the iliacus. It extends out into the abductor muscle group. One rule we like to follow when we ask, where does the lesion even arise from? Is it a soft tissue mass or a bone mass? If you draw the outline of the lesion and put your finger in the middle, like we do here with this red star, we see that the iliac wing is actually the epicenter of the tumor, and what we're seeing on the inside and outside of the iliac wing is a soft tissue mass secondary to a primary bone lesion. Ewing sarcoma has some characteristic findings itself with onion skinning. The other term that can be used is a sunburst appearance. And we look at the x-ray on the left, the black arrow is on this onion skinning appearance. Ewing sarcoma is made up of small round blue cells, and the small round blue cells create a very large soft tissue mass. The layering that occurs from the periosteum in the setting of this onion skinning creates a look that looks like the skin of an onion as you peel the outer layers. When we look at the MRI scan images, the lesion on the left shows you again that very sharp demarcation as the lesion travels towards the metaphysis in the bone, characteristic for a sarcoma. The image on the right shows you how well the cortex is maintained as we see a very large soft tissue mass form around the bone. Again, a Ewing sarcoma is a small round blue cell. I call those little blue cells ninjas, little tumor ninjas, because they can swim outside of the bone through the Haversian canals, create a very large soft tissue mass, and the bone never knows what's happening. So the bone doesn't respond and the bone stays intact. The 4 questions for Ewing sarcoma: location, tumor bone, bone-tumor interaction, and matrix. The location for Ewing sarcoma, as opposed to the osteosarcoma and chondrosarcoma, this is a diaphyseal lesion. It also occurs in the flat bones, the scapula and the pelvis. What's the tumor doing? It creates that very large soft tissue mass that's disproportionate to the response of the bone. The bone likes to make this onion skin and Codman's triangle. And then the matrix is a small round blue cell matrix. It's not as easy as seeing the bone for an osteosarcoma or the cartilage of a chondrosarcoma. Again, Ewing sarcoma occurs in younger patients. These patients are skeletally immature. Here's an example of the same scapula I was just showing you. The lesion on the left is an AP view of the scapula. The image on the right is a lateral view of the scapula. If you look close to the chest wall, you can see a very small amount of reaction along the inner aspect of the scapula. But when we look at the MRI scan, this is a huge soft tissue mass and a lot bigger than you would expect on the plain imaging. Again, that big soft tissue mass that a Ewing sarcoma will form. The yellow arrow is on the glenoid, and you can follow the scapula down from this. The red arrows are on the huge soft tissue mass. When we biopsy a Ewing sarcoma, it's a small round blue cell tumor. It creates pseudo-rosettes when you look at the H&E staining. It has a very specific immunohistochemical profile with CD9 positivity. Ewing sarcoma now is diagnosed with the 1122 reciprocal translocation. This translocation codes for the EWS-FLI1 oncogene. We now have an immunohistochemical stain that stains for the EWS-FLI1 loci specifically. But without one of these 2 findings, 1122 translocation or the presence of the EWS-FLI1 oncogene, we can't make this diagnosis. Ewing sarcoma, again, can look very much like infection, so culture what you biopsy and biopsy what you culture. This image shows you an infection, and how I'm going to show you how it differs from a Ewing sarcoma. An infection has multiple different cell types throughout. You can see in the center of this picture there are megakaryocytes that are phagocytizing all of the small cells that occur around it. In contrast, the image on the left is a Ewing sarcoma, blue cell after blue cell after blue cell after blue cell. Treatment for Ewing sarcoma, the same as osteosarcoma: neoadjuvant chemotherapy, surgery, and chemotherapy. The majority of times we're able to provide limb salvage or wide excision. We have to be careful if a patient has had a pathologic fracture or has had an inadvertent treatment when the patient may require an amputation. Metastatic bone disease is exponentially more common than the 3 primary bone tumors we just looked at. In a patient who's greater than 50 that presents to you with a lytic bone lesion, metastatic disease should be suspected until proven otherwise. When a patient has a previous history of cancer, especially one of the common osteophiles, you need to consider metastatic bone disease. The common osteophiles are prostate, thyroid, breast, lung, kidney. I remember these as P.T. Barnum likes kids, but the young generation doesn't seem to know who P.T. Barnum is, so you can also remember a BLT with a kosher pickle. When you have a patient who's over 50 with a lytic bone lesion, a chest, abdomen, and pelvis scan, or a CT times 3, we'll find the primary lesion the majority of the time. That's because the prostate, thyroid, breast, lung, and kidney occur in the cavity that is focused on by the triple CT scan. A whole body bone scan is very helpful for staging. It's going to look for more bone lesions, but it's not going to help define anything more than the fact that there are more than one lesion. There are also some disease-specific tests that can be helpful, but ultimately we end up at a biopsy to make the diagnosis. So in a patient who presents with a new lytic lesion in the bone, a biopsy is necessary to make a diagnosis. We can use some clues to help guide us as to the origin of the lytic lesion: PSA for prostate, ultrasound for thyroid, mammogram for breast, a chest x-ray or a chest CT for lung. A CT scan of the abdomen will locate the primary lesion when renal cell carcinoma is present. I often remember myeloma, lymphoma, along with metastatic disease because it often has the same presentation and acts in a similar manner. A serum protein and urine protein electrophoresis are very specific to help identify myeloma, as is a skeletal survey. and lymphoma can be identified with multiple lymph nodes on a triple CT scan. Again, metastatic bone disease needs to be diagnosed with a biopsy. When you get a biopsy, you'll see what is present in this image. Mature lamellar bone that's being eaten, busted by a gland. When you see mature bone next to nests and glands of cells, there's a problem, and that's metastatic disease. The primary tumors, prostate, thyroid, breast, lung, kidneys, are lesions that form glands. And when a gland is present in bone next to mature bone, that's metastatic bone disease all day long. The yellow arrow shows you the nest and gland, and the longer arrow shows you the mature bone and how they abut. Metastatic bone cancer needs to be treated aggressively. These patients have very good treatment nowadays. They live a lot longer, so we want to be much more aggressive with them. Pathologic fractures that occur in the lower extremity, that have cortical destruction and are painful, need surgery. The treatment has to be much more aggressive than we would use for a patient who's had a normal bone that had a trauma. We use adjuncts such as polymethyl methacrylate, we use long plates, we may use a nail in some settings, and we want to try to fix the whole bone to avoid areas that may be unprotected if metastatic disease presents at a later time. An important feature of treating metastatic disease is we want to use radiation therapy as an adjunct because we aren't able to remove all of the micrometastatic disease. When we treat the bone, we spread some of that disease, and the important thing is that the entire field needs to be treated with radiation. If you put a nail in the patient, or nailing a femur, for example, the entire femur needs radiation because the entire femur has been seeded potentially with tumor. If you're unsure as to when a patient may or may not need therapy, there's a great prediction tool, Morell's classification. This looks at the variables including the site, upper limb, lower limb, or paratrochanteric femur. A paratrochanteric femur is at a greater risk of a fracture, so it gets a higher score. Pain, which is mild, moderate, or functional. Functional would be ambulatory pain. Whether the lesion is blastic, like prostate cancer, mixed lytic blastic, or lytic, like kidney cancer or lung cancer, the score goes up. And then, of course, the size of the lesion, 1/3, 1/3 to 2/3, or 2/3. This is referring to the actual size of the lesion affecting the cortex. When you look at these scores, they're pretty tight, but it can give you an idea. A patient who has a score under 7 may not require therapy. It may be considered for 8 or greater, and the higher the number gets, the more strongly you want to consider. Here's an example. Here's a patient who presented with a lung metastatic disease to the femoral neck. The lesion extends down to the lesser trochanter, so this is paratrochanteric and garners a score of 3. The pain is functional. If I tell you the patient has pain with weight bearing, the lesion is lytic. And the size of the lesion, if you look on the AP and lateral, appears to be about half the cortex. So we get a total score of 11. This is a patient who definitely needs surgery. This is a patient who had resection of the bone and a long stem hemiarthroplasty. I want to show you some questions and answers because this is such a common scenario and the most likely thing to show up on your exam. If we look at the radiographs of a 73-year-old woman with a history of breast cancer and ambulatory thigh pain, so she has pain with weight bearing. We know she has a history of breast cancer. We're even told a needle biopsy confirms metastatic breast cancer. The question is, what's the best treatment strategy? If we look at her imaging, we see a metadiaphyseal lesion. The lesion is lytic. It is involves the lesser trochanter, so it's paratrochanteric. And the lesion involves about half of the cortex. If we compare the cortex below to the cortex above, we can see if we combine that, it's about half. So this patient, if we add up her score, having a paratrochanteric lesion of 3, she's got a lytic lesion, that's a 3. She's got pain with weight bearing, we're all the way up to 9. And then lesion being in the range of about half, we get to 11. So this is a patient who needs surgery. The question is, what type of surgery? Well, the lesion is not large enough or aggressive enough in the head or neck to require a femoral resection, but we want to consider internal fixation. And as I just told you, this patient is going to need radiation therapy if we put a femoral nail in. So the best answer here is number 3, prophylactic internal fixation and radiation. This may also come to you as an answer such as this, surgical stabilization. So they aren't as specific in asking you what type of surgery, but surgical stabilization combined with radiation and bisphosphonates. Bisphosphonates are extremely important in providing apoptosis to the osteoclasts that are destroying the bone. They're very commonly used in patients with metastatic disease. Now you may ask yourself, we had a patient who had breast cancer, she had biopsy-proven breast cancer, why aren't we using hormone therapy? We were given absolutely no information about the hormone receptor status. We don't know if she's ER/PR positive or not, so we don't know whether hormone therapy is appropriate or not. Here's an example of where that may come into play. A 65-year-old woman who sustained a pathologic hip fracture has breast cancer and multifocal metastatic lesions. In addition to estrogen receptor status, what other test will help the medical oncologist? The appropriate answer here is number 4, progesterone and HER2/neu. Today, estrogen, progesterone, and HER2/neu status are important and have specific endocrine targets. So a patient who may be ER/PR positive, HER2/neu positive, or if all receptors are positive, they may have targeted therapy that may be directed to them. If those are negative and all negative, these patients receive cytotoxic chemotherapy. So it's important to know that just because a patient has breast cancer doesn't mean they get treated with hormonal therapy. What about soft tissue sarcomas? Soft tissue sarcomas are actually about 4 times more common than bone sarcomas. Patients will present to the clinic with a lump or a bump or a mass, and it's important to note that their MRI scan imaging is very specific. The lesions are dark on T1, they become bright on T2 imaging. This includes high-grade liposarcomas. The lipomas are much more common, and it's very important to be able to distinguish the imaging. Here's an example of a lipoma, and the arrow is showing you the T1 weighted image on the left, where the lesion at the tip of the yellow arrow is the exact same as a subcutaneous fat. The lesion on the right is a T2 fat suppression image, and you can see that the lesion disappears when the fat is suppressed. The subcutaneous fat disappears and the fat lesion disappears. So a true lipoma, a true benign fatty lesion should follow fat on every single sequence. Here's an example of a dedifferentiated liposarcoma, and if we look at the lesion, the red arrow is actually on the highly malignant dedifferentiated part. The red arrow is on the low-grade fatty part of the lesion, which is exactly the same as a subcutaneous fat. When we now do a T2 suppression image, the yellow arrow shows you that the dedifferentiated, highly malignant portion of the tumor that's not fat doesn't suppress, but the low-grade fatty portion of the lesion does. So benign fat, low-grade fat should follow fat on every single sequence. Soft tissue lesions require appropriate evaluation before they're resected. A lesion that's bigger than 5 centimeters, deep to fascia and growing needs 3-dimensional imaging. That appropriate imaging can lead you to whether the lesion is fat, like I just showed you. If it's not, you need a biopsy. And again, don't be fooled. Soft tissue sarcomas can have a very long, slow, painless, insidious onset, but still be malignant. And again, that's important in your STEM. Just because a patient presents to you with a growing mass that's not painful doesn't mean it can't be a sarcoma. A very common test question and a common scenario people may encounter in practice is, what do you do with the unplanned excision? A patient presents to you with a mass, you remove the mass, send the lesion to pathology. Pathology comes back to you, lo and behold, the sarcoma. What do you do? The important thing to remember is that you have to do something. These lesions can't be left alone. So the treatment, most commonly in the setting of an unplanned excision, is to excise the lesion back to negative margins. Oftentimes this requires some sort of flap and radiation. This patient had a superficial thumb lesion that underwent 2 excisions. The lesion kept recurring. We had to take the patient back for a very wide resection and a radial forearm rotational flap. So again, an incompletely excised sarcoma has to be excised to negative margins. Further treatment is warranted. This means a wide excision and may or may not involve a flap and radiation. The key items for a soft tissue sarcoma that are bad: size, grade, and depth. So a lesion that's bigger than 5 centimeters, high grade, deep to the superficial fascia, it has a worse prognosis. Soft tissue sarcomas, just like the other sarcomas, bone sarcomas, are staged with a CT scan of the chest. The most common soft tissue sarcoma to be tested is a synovial sarcoma. There's a very specific translocation at the X18 locus. These also have a fusion transcript of the SYT-SSX gene. They are so specific to synovial sarcoma, and very few soft tissue sarcomas have them. The synovial sarcoma seems to be the most common soft tissue sarcoma tested. Again, bigger than 5 centimeters, deep and growing, should warrant some sort of investigation. Lesions about the wrist and hand that are about 1.5 centimeters should raise a greater level of suspicion in you. Most ganglion cysts, fibrous lesions, or other are less than this, and we want to take care in evaluating these lesions prior to excision. I talk about an unusual presentation here, and the reason is that a fatty mass that recurs is unlikely to be a lipoma and should garner special attention. Giant cell tumors of bone are benign lesions. They're benign aggressive, but for some reason are very commonly seen on the recertification exam. These occur typically in patients who are skeletally mature, so more commonly patients who are approaching 30. When we talk about location, tumor-bone, bone-tumor interaction, these are epiphyseal lesions. They are benign aggressive, so the lesion has some features of being aggressive but not overtly. When we see that the lesion on the metaphyseal side of the bone has a border to it that can be defined sharply, we see that the bone responds by expanding. We don't see a lytic destruction of the bone, but we see a very slow expansion of the outer bone. And then the matrix is giant cell. So again, you're not going to see much in the way of matrix, not a nice bone or a cartilage matrix when you see these lesions. But they may be lytic, eccentric, poorly defined once they progress if they've been ignored. The characteristic finding for a giant cell tumor on biopsy is that there are giant cells, but the giant cells have a nuclei that appear the same as the stromal cells outside. And someone described this to me once, and it seems to make sense. These look like really big chocolate chip cookies with a bunch of chocolate chips in the middle, but then the chocolate chips have spilled around the edge. It kind of makes sense. But a lot of lesions can have giant cells in them. A giant cell doesn't make a giant cell tumor. But that characteristic finding of a big giant cell with a nuclei the same as the stromal cells is characteristic for a giant cell tumor. Giant cell tumors need to be treated. So the important thing about giant cell tumors is they cannot be observed. They can often occur in concert with an aneurysmal bone cyst. And these are lesions that have to undergo some sort of treatment. The treatment may be aggressive intralesional resection. That's what we prefer. How you reconstruct them doesn't matter. Bone graft, cement, plate, screws. The important thing is that a very large appropriate resection occurs. Sometimes people undertreat these lesions because they're benign. Very few, less than 5% metastatic rate occurs, but they need to be treated aggressively because they can have a significant local recurrence rate as high as 30%. We're going to talk about aneurysmal bone cysts and unicameral bone cysts. Again, very common lesions to see on the exam. And they have very different features that can be confused. Aneurysmal bone cysts and simple bone cysts or unicameral bone cysts are younger patients' disease. These usually present before patients are 30 years of age. An aneurysmal bone cyst is a cystic, aggressive appearing lesion. And the thing about aneurysmal bone cysts is they don't occur alone. They usually have an accomplice, or they usually occur as a collision lesion. So they can arise with a giant cell tumor, chondroblastoma, chondromyxoid fibroma, fibrous dysplasia. They can occur with many lesions. And the characteristic thing for an aneurysmal bone cyst is it may have a well-defined border on one side, but it's eccentric and expansile, hence the term aneurysmal. Usually these tumors are metaphyseal. So if we look again, location, tumor bone, bone tumor interaction, we have a metaphyseal lesion that is expanding the bone slowly over time. The bone responds very slowly with a very thin cortical expansion, and the matrix is fluid. And here the arrow shows you the lesion as it expands on the outer aspect of the bone, but a very well-defined sharp border on the inner metaphyseal area. When we look at the MRI scan associated with this X-ray, we see multiple channels and fluid levels or fluid-filled spaces. Again, fluid levels are not specific to an aneurysmal bone cyst per se, but we see aneurysmal bone cysts occur with other lesions, so we often see this. You do have to be careful in your differential when you do see an aneurysmal bone cyst to consider a telangiectatic osteosarcoma. Usually these have destroyed the bone more significantly and create a lot more edema than an aneurysmal bone cyst does. The arrow is showing you one of the large channels, and here's the histology that follows with this. The pathology here shows these large cystic spaces filled with blood. There may be giant cells, and in between are areas of reactive woven bone. So we have small little channels that this woven bone has created. These also show up as fibrous septae. you can imagine that the blood that you see in this, once it settles down on a scan, will create a straight line as it settles, just like water settling in a glass creates a straight line at the interface. The important thing for aneurysmal bone cysts is they cannot be observed, they occur with other lesions, they're aggressive, and they progress, so they need aggressive treatment, curettage, and some sort of adjunct treatment. A simple bone cyst or unicameral bone cyst occurs in the same age group. The difference is it is one large cystic channel. These patients often present with pain due to a path fracture, but the difference is a simple bone cyst occurs alone and can undergo a different treatment course. The pathognomonic finding for a simple bone cyst is the fallen leaf sign. So the inner aspect of the bone has a very thin rim of bone that has walled off the lesion. When the lesion fractures, that small little piece of bone will float down the fluid level, and it almost floats like a leaf falling in the wind, hence the term fallen leaf sign. An important finding for a simple bone cyst, and I'll show you in a minute, the lesion itself does not extend, it's not aneurysmal, and it is the same size or smaller than the physis it is close to. Active lesions abut the physis. Here is a latent lesion that has normal intervening bone. It may be important to differentiate the two in that an active lesion may require more aggressive treatment. A latent lesion may be followed and allowed to heal and just observed over time. A simple bone cyst on MRI scan, as opposed to the very small channels and fluid levels seen on an aneurysmal bone cyst, a simple bone cyst has one large channel. Within it, there may be one large fluid level or no fluid level. And a simple bone cyst on histology then follows that same logic. Here you see one area of cystic lining below, and when you look at the top of the histology slide, you see a big space filled with fluid. So the aneurysmal bone cyst has multiple small channels and fibrous septae. A simple bone cyst only has a lining and then a large space around it. Simple bone cysts, once they fracture or even if they don't fracture, can be observed depending on the symptoms that the patient has. Because it's one large channel, it may be aspirated, injected. If it's recalcitrant, it may be curetted. The important thing is that these lesions can be treated differently than an aneurysmal bone cyst because they don't progress. And here's a side-by-side comparison again. An aneurysmal bone cyst commonly occurs with other lesions, so-called collision lesions. A unicameral or simple bone cyst does not. A simple bone cyst has a fallen leaf sign associated with it. An aneurysmal bone cyst does not. An aneurysmal bone cyst on plain X-ray is eccentric, and the width of the tumor is greater than the width of the physis it borders. In contrast, a unicameral bone cyst is the same width or less than the width of the physis. An aneurysmal bone cyst has to be treated. Often the treatment is open curettage. You cannot aspirate and inject an aneurysmal bone cyst because of all of those really small channels. You can't get into all of them with an aspiration and injection. In contrast, a unicameral bone cyst is one large fluid-filled channel. It can be aspirated and it can be injected with steroids, bone marrow aspirate. There's no consensus on what the treatment could be. Here's an example on the left, an aneurysmal bone cyst, and here's the physis. And then when you look at the lesion, you can see the lesion itself is at least 1.5 times larger than the physis. The lesion on the right is a simple bone cyst, and when you measure the width of the physis, the lesion itself is about the same size. So patients, when they present, obviously don't present with histology, pathology, and in the form of a question. They present by location, and I like to present this for people because it's helpful. When you see an image, you can often narrow down your diagnosis just by the location of the tumor. When we talk about tumors by location, we're talking about epiphysis, metaphysis, diaphysis, the flat bones, such as the scapula and the pelvis, the spine, the sacrum, and surface. And I showed you earlier the surface osteosarcomas, such as a parosteal and a periosteal osteosarcoma. The big areas to concentrate on are the epiphysis, metaphysis, and diaphysis. Very classic for chondroblastoma, giant cell tumor, and clear cell chondrosarcoma with the femoral head to occur in the epiphysis. Most commonly, chondroblastomas, as seen here, are in skeletally immature patients. Giant cell tumors occur in skeletally mature patients, so chondroblastomas are usually in younger patients, giant cell tumors in older patients. Clear cell chondrosarcomas can occur in any age group but are very specific to the femoral head. Metaphyseal lesions, osteosarcomas, chondrosarcomas, and metastases. And then diaphyseal lesions, just like we learned in grammar school for our vowels, A, E, I, O, U, and sometimes Y. Adamantinoma, very common to occur in the tibia. Looks like soap bubbles throughout the bone. The lesion has some chronicity to it, so we see an expansion and bowing of the tibia. Eosinophilic granuloma is the E, also known as histiocytosis. It's a diaphyseal lesion that looks like a die punch or a direct punched out lesion of bone. Infection, very common to occur in the diaphyseal bone, and you can see here that the infection has gone up and down the diaphysis. As the infection is spread outside the bone, it has created multiple layers of cortical response. So AEIO, osteoid osteoblastoma. The image here is an osteoid very classic eccentric lesion. It's on one side of the bone, has a very smooth border. And an osteoid is purely a bone response to the very small target lesion of the osteoid. The prostaglandins that are produced by the osteoid irritate the bone in the periosteum, and basically bone just makes a large area of bone. So AEIOU is Ewing sarcoma, diaphyseal location. We talked about Ewing's being that small round blue cell tumor. Those little tumor ninja cells, those little blue cells swim outside the bone, create a very large soft tissue mass. And then fibrous dysplasia. Fibrous dysplasia deforms the bone over time. It creates what we call a ground glass appearance. The fibrous dysplasia is very thick fibrous tissue that sits inside the intramedullary canal. And instead of getting an x-ray that shows 2 cortices, it actually is like looking at 3 cortices because the fibrous tissue is so thick. That's why you don't see the normal structure and architecture of bone. You see what looks like this ground glass appearance. So diaphyseal location, AEIOU, and sometimes Y. What about biopsy principles? Well, biopsy principles are the most important part of staging. Biopsy is so important that if it's not done properly, it can create a patient to have an amputation or can totally preclude limb salvage. So if given the option on the exam, consult a musculoskeletal oncologist in how you do a biopsy or if you have a question about a biopsy. The principles of biopsy are these: a longitudinal incision in line with a future resection. This is important because at the time of definitive surgical excision, the biopsy tract is going to be removed. A horizontal biopsy changes the way a surgical incision is made. It can change soft tissue flaps and create infections and unnecessary surgery. You want to avoid critical structures, so you really need to pay attention to the anatomy and think about when a biopsy occurs, what's going to be removed when that biopsy happens. So I draw out my entire surgical incision for the future. I draw out where my biopsy is going to be. I draw out what the excision of that biopsy tract is going to be to make sure that I'm not going to affect anything important. I've shown you how these lesions can have soft tissue components, and ideally we biopsy the soft tissue component when present. First off, there's less processing that occurs to the tumor, so we're able to make a better diagnosis. And possibly more importantly, when a hole is made in weak bone, we make the bone even more predisposed to a displaced pathologic fracture. Finally, maintaining strict hemostasis is important. What this does is avoid contamination outside the biopsy tract. It will eliminate iatrogenic tumor spread. And if you had to place a small drain in order to maintain hemostasis, that is preferred over having a patient present with a very large bruise and bloody field later. Hazards of biopsy and definitions of biopsy: an incisional biopsy versus an excisional biopsy. An incisional biopsy is a small incision, an incision that's 1 to 2 centimeters. The area has minimal violation, tissue is taken, and the area is closed. We perform this when we're completely unsure of a diagnosis, or we need to have a large amount of tissue, or when a lesion is bigger than 3 centimeters, or 1.5 centimeters in the hand or foot. An excisional biopsy is performed when the lesion is less than 3 centimeters, or the size of the incision for a biopsy would be about the same size as the incision for a resection. The important thing to think about here is that an excisional biopsy assumes that the lesion will be excised with negative margins. So you can't shell out a tumor or inadequately remove a tumor. If you're going to do an excisional biopsy, the entire lesion needs to be removed with a very small cuff of normal tissue. Here's an example of a patient, unfortunately, who had an inguinal lesion. The biopsy was performed directly through, you guessed it, the nerve, artery, and vein, navel to the navel. This patient had to undergo a hindquarter amputation because we couldn't save the blood vessels, we couldn't save the nerve. The biopsy was going to remove all of those when we did our re-excision. I want to share with you some mnemonics to maybe help you remember also on the exam. There are 4 big mnemonics I like to remember. I've already shared with you A, E, I, O, U, and sometimes Y. The other ones are your blue cell tumors, MELT, and ESARC. Your blue cell tumors, learn them, L-E-R-N-M. Lymphoma, Ewing sarcoma, rhabdomyosarcoma, neuroblastoma, myeloma. These are important because they're very difficult to distinguish from one another. Lymphoma and myeloma, when we look at them, occur in patients who are over 30, so it's an older person's disease. Ewing's, rhabdomyosarcoma, and neuroblastoma occur in patients under 30. So immediately there's a differentiation between those. Ewing sarcoma, as we discussed, has specific findings: 1122 translocation, the FLY1 oncogene, CD99 positivity. Rhabdomyosarcoma has a specific immunohistochemical finding in its Desmond positivity. The other important finding is rhabdomyosarcoma and neuroblastoma are soft tissue lesions. So you need to look at whether the lesion occurs in a bone or soft tissue, whether the lesion is in a patient under or over 30, and then there are some specific findings that can help you narrow down what a blue cell tumor is. So if you look at the histology and you see a small round blue cell tumor, hopefully you can learn them. Lymphoma, CD45 positive. Remember I told you lymphomas and Ewing's can both have that huge soft tissue mass. Those small round blue cell ninja cells can swim right out the Haversian canals. But a lymphoma is going to have CD45 positivity as well as LCA or leukocyte antigen positivity on immunohistochemistry. Myeloma, again an older person's disease, you're going to see in their blood or urine a monoclonal spike. We're also going to see when we stain the tissue IgG, IgA, or lambda light chain reactivity. There's also a plasma cell malignancy, and on the touch prep you often see those big eccentric clock-face nuclei. What about melting? Well, we talk about melt because it looks like a vertebral body path fracture. The vertebral body has just melted away. And a nice mnemonic for remembering that is metastases myeloma, eosinophilic granuloma, lymphoma, leukemia, and trauma or tuberculosis. The most common of these that presents with vertebra plana is eosinophilic granuloma. Usually occurs in a younger patient population. Soft tissue sarcomas with lymph node metastases. Now remember, our sarcomas like to spread to the lungs. They spread by hematogenous dissemination, and we want to get a chest x-ray or a CT scan to evaluate for metastatic disease. But there are 5 soft tissue sarcomas that have a propensity to travel to the lymph nodes, so you need a good lymph node examination and good evaluation. These 5 tumors are epithelioid sarcoma, synovial sarcoma, angiosarcoma, rhabdomyosarcoma, and clear cell sarcoma. Well, why is this important? You may be given on your exam a soft tissue lesion. You may be told it's X18 positive, and that would lead you to synovial sarcoma. The question may then come, in addition to chest imaging to evaluate for metastatic disease, the important area to identify and evaluate is, and the answer is lymph node metastasis. So although these lesions have a predilection to go to the lymph nodes, still the majority of the time they metastasize to the lungs. Just to review the treatment again, because this is going to be important in being able to answer your questions, you're often going to be given a scenario in which you have to determine and are assumed to know that a lesion is, say, an osteosarcoma, but you need to know what treatment exists. Chemotherapy and surgery is used for osteosarcoma and Ewing sarcoma, so those patients get chemotherapy, surgery, followed by chemotherapy. Chondrosarcoma receives surgery alone. Remember I told you those chondrosarcomas are very slow growing, they're very slow expanding, and the chondrosarcoma doesn't move fast enough to have weak spots. So it can't really be affected by chemotherapy, not affected by radiation. Soft tissue sarcomas get radiation and surgery. Radiation can be given before surgery, it can be given after surgery. It doesn't affect local recurrence, it doesn't affect outcome. It affects, when given prior to surgery, wound healing. When given after surgery, because the dose is larger to a bigger area, These patients can have long-term complications like stiffness, edema, and other complications. Good luck on your exam, and thank you.